welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you are attending virtually, you may enter your question in the Q&A section. Also, a link to this event survey will be shared in the chat section toward the end of the program. If you are ABS certified and want NGHS to report your CME credits to the ABS, please fill out the evaluation and give us permission to do so. And now it is my pleasure to introduce our guest speaker for this morning. Originally from the Speedways of Talladega, Alabama, Dr. Harvell earned his bachelor's degree from Jacksonville State University, graduating summa cum laude in biology with a minor in chemistry. He earned his medical degree from the University of South Alabama. Dr. Harvell's surgical interests include acute care surgery and the bread and butter, general surgery. Outside of medicine, he enjoys spending time with his family, backpacking in the Cheaha wilderness of the Talladega National Forest, woodworking, golfing, hunting, fishing, and trying his hand at new hobbies and crafts. Please join me in welcoming Dr. Tyler Harvell.
I'm Tyler Harvell, and the title of my presentation is From Halsted to Modern Surgery, the Journey of Axillary Management in Breast Cancer. I chose this topic, number one, because frankly, I enjoy taking care of breast cancer patients. Love Dr. Strom's service. These patients face challenging diagnoses, and I find great purpose in providing surgical care that is both evidence-based and compassionate. The axilla itself represents a fascinating aspect of breast cancer management. Historically, the axilla has been a focal point of treatment that's seen remarkable evolution from the radical approaches that were pioneered by Halsted to the more nuanced patient-centered strategies that we use today. I think I'm most excited about this topic because of how rapidly the landscape is changing. With advances in imaging and systemic therapy as well as radiotherapy, we're seeing that it's truly reshaping how we approach the axilla, which makes it an important topic to understand and discuss. I have no financial disclosures. So these are my learning objectives. I wanted to start out talking about the evolution of breast surgery and axillary surgery, and kind of show how things have changed as far as de-escalation of interventions. And so once we look at where we've been, I want to look at where we are now. What are the current indications for axillary surgery and for patients with breast cancer? Then we'll talk a little bit about the techniques, how these procedures are done, different agents that are employed. Then we'll discuss the morbidity and financial implications associated with axillary surgical procedures, which is really what drives this trend to try to de-escalate our interventions. And then lastly, we'll look at the new evidence into the selective use of axillary surgery. There are a couple of papers that I'll talk about that are out and published, and there are a couple of other trials that I'm going to talk about that are currently underway. So as far as the history of breast cancer, breast cancer is the most common cancer among women, with about 42,000 deaths in the U.S. every year. In 2020, there were 2.3 million women who were diagnosed with breast cancer, and there were 685,000 deaths globally. So it's a significant surgical problem, significant disease process, but it's been described since ancient times. Around 3000 BC, the Edwin Smith surgical papyrus, which was an ancient Egyptian medical text, provided some of the first authentic accounts of breast cancer. One of the quotes from the text said the cases were deemed incurable if the disease was cool to touch, bulging, and spread all over the breast. 400 BC, Hippocrates proposed that the cause of disease was an imbalance of the humors. And he proposed that there were 4 humors: blood, phlegm, and yellow and black bile. In 168 BC, Galen doubled down on this and proposed that a breast tumor was a coagulum of black bile. And then in the 1st century, Leonidas of Alexandria was credited with the first mastectomy. However, up until the 1500s, medical progress was stagnant, and that was because it was intertwined with a lot of religious philosophies. Around this time, particularly Christians were believed more in faith healing, and was often viewed as sacrilegious to go seek the advice of a physician. However, with the advent of anesthesia and strong anatomical exploration, surgery emerged as an independent discipline, basically cleaving from its association as a barber's trade. In the 16th century, Andreas Vesalius, who is credited as the father of anatomy, published De Humani Corporis Fabrica, which translates to the structure of the human body. I don't know if you've ever seen images from the text. It is impressive. Incredibly detailed illustrations of anatomy, great descriptions of the anatomy. In 1757, Henry Ledron, he was a French surgeon who postulated that breast cancer progressed in stages and advocated surgery to prevent the spreading of breast cancer. In 1838, Johannes Mueller suggested that cancers were composed of living cells and suggested that metastasis was due to the spread of these cells. Astley Cooper better described the anatomy of the breast. We're all familiar with Cooper's ligaments. Philibert Sappi described the subareolar plexus of lymphatics, and this would essentially provide the theoretical basis for subareolar injection for lymphatic mapping. And then there were accounts in 1870s, 1880s of en bloc resections performed by Charles Moore in London and axillary node dissections by William Banks in Liverpool. However, despite these treatments, 5-year survival for breast cancer was only estimated at around 20%. And so it would be the father of modern surgery who would usher in the golden age of surgery. William Stewart Halsted, he is credited with, formulating the general surgery residency. He's also credited for the paper chart as well as the rubber gloves that we use in the OR. In my opinion, he's one of the greatest surgeons as far as breast surgery goes until, Dr. Strom came along and changed everything for us. So it was at the turn of the century that breast cancer surgery became synonymous with the name William Halsted. It was in 1894 that he first described the radical mastectomy, and he emphasized removing tissues in one piece to prevent spread and removal of the pectoralis muscles to prevent recurrence. And in his paper, he was quoted as saying, "The suspected tissue should be removed in one piece, lest the wound become infected by the division of tissues invaded by the disease or of lymphatic vessels containing cancer cells. And because shreds or pieces of cancerous tissue might readily be overlooked in the piecemeal extirpation." And in his paper, the results in terms of local recurrence were exceptional. And the question is, at what cost? And as you can see in these photos, these women have undergone a radical mastectomy And you can see how disfiguring it is. You know, you can see the rib cage, significant scarring in the far right picture. The woman has a compressive sleeve for lymphedema. And so despite the morbidity, the radical mastectomy would be performed on more than 90% of breast cancer patients for nearly the next 80 years. And it seemed that there was a lot of resistance to change. And Halsted himself was quoted as saying, "After all, disability ever so great is a matter of very little importance as compared to the life of the patient." It wasn't until 1932 that the first to question the utility of the radical mastectomy were Dean Lewis and William Reinhoff, who were two surgeons trained by Halsted. And in their paper published in the Annals of Surgery in 1932, this was basically a long-term follow-up of 950 patients that were treated by Halsted and his followers. And their results differed from what Halsted's paper showed, because what they did was focus more on overall survival rather than local recurrence. And what they found was that at 3 years, survival rates were 46%, 5 years, 24%, 10 years, 8%, 15, 4, 23. And breast cancer among those deaths was the cause of 96%. And so this revealed that, you know, overall survival was around about the same compared to patients that were treated before he described his radical mastectomy. So in the following decades, it was British surgeons David Patey and John Madden who introduced modifications to the radical mastectomy that basically that spared the pec muscles. And in Europe, it was widely adopted. However, in the US, it remained the standard of care. So it was in 1948 that Patey demonstrated that in 18 patients, there was no difference in survival or local recurrence between patients going pec major sparing operations and those having standard radical mastectomies. And then in 1970, John Madden demonstrated that it was possible to clear the axilla and preserve the pec muscles with their neurovascular supply with similar outcomes. And so it was in 1972 that he published his paper on the modified radical mastectomy. And essentially what he did was compared outcomes, 5-year survival, 10-year survival, and local recurrence between the modified radical and the radical mastectomy. And you can see that in node positive and node negative groups, survival is pretty much the same as far as 5-year survival, 10-year survival, and local recurrence at 10 years was essentially the same. And so it was basically from this paper that the modified radical mastectomy became the standard of practice. And so dissatisfaction with the significant morbidity of radical mastectomy led to anecdotal reports of surgeons using less aggressive surgery to treat breast cancer. The National Surgical Adjuvant Breast and Bowel Project, NSABP, conducted the NSABP B4 trial in 1971, which compared radical mastectomy to less invasive surgery. So they took patients who were node negative and they randomized them to radical mastectomy, total mastectomy plus radiation, and then total mastectomy. And mind you, total mastectomy does not include any axillary intervention. And then node positive breast cancer, those patients were randomized to radical mastectomy and total mastectomy plus radiation. And what they found was that in the node negative breast cancer, local regional recurrence in the total mastectomy plus radiation was 5% compared to 9% in the radical mastectomy and 13% in the total mastectomy. And that was statistically significant, which I think, you know, really shows the importance of radiation. Radiation I think is what really reduced local regional recurrence. And in node-positive breast cancer, the results were about the same, 16% in the radical mastectomy group, 14% in the total mastectomy plus radiation, and it was not statistically significant. And so following this study, we start to see de-escalation of surgery, particularly in node-negative patients, from the radical mastectomy to more mastectomy plus radiation. To further minimize the extent of surgery, several investigators evaluated breast conserving surgery and reported encouraging results in small studies that included patients with small tumors. And so the NSABP conducted the B6 trial comparing total mastectomy versus breast conserving therapy. So they took patients with breast cancer tumors that were less than or equal to 4 centimeters, regardless of nodal status, and randomized them to modified radical mastectomy, lumpectomy plus axillary node dissection plus radiation, and then lumpectomy plus axillary node dissection. So all 3 groups had axillary surgery, but one was modified radical, lumpectomy plus radiation, and lumpectomy. And so their primary outcomes were overall survival. As far as lumpectomy alone versus total mastectomy, the hazard ratio was 1.05. A hazard ratio of 1 means there's no difference. And so it was 1.05, and it was not statistically significant. So lumpectomy alone versus total mastectomy for patients with breast cancer less than or equal to 4 centimeters was pretty much the same. The same with lumpectomy and radiation versus total mastectomy. Overall survival rates at 20 years was around about the same, around about 46%. And overall survival of lumpectomy with positive margins versus lumpectomy with negative margins, which I found interesting, was also not statistically significant. As far as their secondary outcomes go, they looked at deaths due to breast cancer, and they compared lumpectomy and radiation versus lumpectomy alone. And the lumpectomy with radiation group had fewer deaths compared to lumpectomy alone, which was statistically significant. And the cumulative incidence of recurrence in the ipsilateral breast in women who underwent irradiation after lumpectomy versus lumpectomy alone at 20 years was 14.3% versus 39.2%. Again, kind of highlighting the importance of radiation. And so they concluded that there was no difference in survival between women who underwent lumpectomy followed by radiation compared to total mastectomy. Furthermore, treatment, lumpectomy and radiation reduces the recurrence of breast cancer compared to lumpectomy alone or mastectomy. And so now that we've kind of talked about how we've gone from, these big surgeries with the mastectomy down to lumpectomy, I want to talk a little bit about how we've moved from axillary dissection down to sentinel lymph node biopsy. So to determine axillary status for staging purposes, for adjuvant treatment and regional control, complete axillary node dissections were routinely performed. However, it was found that these patients had significant morbidity with lymphedema, shoulder dysfunction, paresthesias, and pain. And studies showed that only about 20 to 35% of patients who undergo axillary dissection have positive nodes, which means that somewhere around 65 to 80% of patients are having normal healthy nodes removed. And so removing healthy nodes renders no benefit. And so for these reasons, the sentinel lymph node dissection was developed in the early 1990s. The first data from sentinel lymph node biopsies came from node biopsies performed in melanoma cases. But it was in 1994 that Giuliano and colleagues published findings on the feasibility and accuracy of sentinel node biopsy for early stage breast cancer in 114 women, and they were able to accurately predict nodal status in about 96% of cases. And so due to Giuliano's study, the NSABP conducted the B32 trial. And so in this study, there were 5,600 women with clinically node-negative breast cancer, and they were randomized to sentinel lymph node biopsy followed by axillary dissection, and then sentinel node biopsy followed by ax dissection only if the sentinel node was positive. And they looked at overall survival, disease-free survival, and local recurrences. And as you can see, the results are, again, the same, 92%, 92.9 versus 91.6%, as well as disease-free and local recurrence. There really wasn't a difference. And so they concluded that among women with clinically node-negative breast cancer, there's no difference in overall survival between the sentinel lymph node biopsy group and the axillary node dissection group, but sentinel node biopsy obviously had fewer complications as far as nerve palsies, neuropathies, and lymphedema. So once the sentinel node biopsy was shown to be safe in patients with clinically node-negative disease, omission of the axillary node dissection in patients with negative sentinel nodes became the standard of practice. For patients with positive sentinel nodes, most consensus statements recommended completion axillary dissection. But if you remember from the B4 trial, in which those patients that underwent total mastectomy, they had no axillary node dissection, there was no survival benefit for those patients. And so recognizing improvements in systemic and radiation therapy, the utility of the completion axillary node dissection in patients with positive nodes was questioned. And so this is where we see the study that we're all familiar with, the Z11 trial. Axillary dissection versus no axillary dissection in women with invasive breast cancer and sentinel node metastasis. So in this study, there were 891 patients with T1 or T2 tumors and 1 to 2 positive nodes on sentinel node biopsy undergoing lumpectomy with whole breast radiotherapy. And they were randomized to completion axillary node dissection or observation. And the results from this were, again, the same. Overall survival between the two groups were about the same, around 92%. Disease-free survival was about the same, around 82 to 83. And then local regional recurrence-free survival was around 95 to 96%. They also looked at adverse outcomes. So adverse surgical events, all comers, completion, axillary node dissection, there were about 70% that experienced adverse events versus 25%. And in the observation group, significantly less morbidity as far as wound infections, seromas, paresthesias, subjective lymphedema in the observation group, 6% versus 19%. This is what the patient reports. Although objective lymphedema, 6% versus 11%, and that was based off of arm measurements. So they concluded that axillary node dissection does not improve survival or local control compared to nodal observation in patients with T1, T2 breast cancer and positive sentinel node biopsy undergoing lumpectomy and whole breast radiation. And obviously there were fewer adverse events in the observation group. And so the American Society of Breast Surgeons would go on to issue a consensus statement on the axillary management that incorporates these findings, as would NCCN. All right, so now let's talk a little bit about where are we now as far as current indications for axillary surgery in breast cancer. So starting with sentinel node biopsy, patients with invasive breast cancer, that are clinically node negative, undergoing lumpectomy or mastectomy, they get a sentinel node biopsy. And Dr. Strom will harp on you for this one, DCIS, if they're undergoing planned mastectomy, and that makes sense, right? The lymphatic architecture is destroyed after mastectomy, and so, heaven forbid you do your mastectomy and find that there wasn't just DCIS, you actually have invasive cancer. Now you can't go in and do a sentinel node biopsy because you've destroyed the lymphatics. There's also some literature that supports doing a sentinel node biopsy and a DCIS with risk factors for invasion. Tumor size greater than 3 centimeters, high histological grade, or presence of cheminonecrosis. And a lot of this was based off of a paper that was published in the American Journal of Surgery by Chehade et al., and it was a meta-analysis of 48 studies. And so what they did was took around 9,800 patients with DCIS who underwent sentinel node biopsy, and they analyzed the cases in which the sentinel node biopsy was positive and looked to see if there was any correlation with the tumor characteristics. And what they found was that positive nodes directly correlated to tumor size greater than 2 centimeters and high histological grade. And I wanted to include this one in here. I think this one is controversial, but it is an NCCN, and it's based off of some newer studies, the Z1071 trial, and it is clinically node-positive breast cancer patients that convert to node negative after neoadjuvant chemotherapy, but there's a caveat to it. So in this trial, what they found, what they did was there were 637 patients with node-positive disease that were treated with chemotherapy and sentinel node biopsy, followed by axillary dissection. And they were able to correctly identify nodal status in 91.2%. However, the false negative rate, and this, mind you, this is what matters. When you're doing a sentinel node biopsy, what matters is your false negative rate. You don't want to have a false negative when they could truly have a nodal metastasis. And from this study, they found that their rate was 12.6%, which is higher than the acceptable 10%. However, they did a sub-analysis to look at if the technique of how they performed the biopsy resulted in a lower false negative rate. And they found that when the surgeons used dual tracers, so the radio tracer plus a blue dye, the false negative rate was at 10.8%, but the big bang for the buck here was number of nodes. And so if they found that if you could get 3 sentinel nodes, the false negative rate was around 9%, and 4 sentinel nodes, false negative rate was around 6.7%. So current indications for axillary surgery and breast cancer. So for your axillary node dissection, invasive breast cancer in which sentinel nodes were not identified. Invasive breast cancer with positive nodes that don't meet that Z11 criteria. Nodes that were biopsied prior to surgery and found to be positive with no plan for neoadjuvant chemotherapy, those patients will get an axillary node dissection. Nodes that remain clinically positive after neoadjuvant chemotherapy, and then recurrent breast cancer and inflammatory breast cancer. And I threw this up here for everybody that was trying to remember the slides. I know I'm a visual learner, and so I just wanted to put the NCCN algorithm up there. And as you can see, again, node negative with no sentinel nodes identified, axillary node dissection. If they don't meet the Z11 criteria, axillary node dissection. If they are node positive and there's no plan to receive neoadjuvant chemotherapy, they get an axillary node dissection, and then the ones that remain clinically positive afterwards will get an axillary node dissection. All right, so now let's talk about how how these procedures are performed and what techniques are used and agents that we use. So as far as the sentinel node biopsy, there's the blue dye that we've all seen. There's the 1% isosulfan blue. This is associated with severe anaphylactic reactions, although it's pretty rare, 0.16 to 1.1%. Although I know that Dr. Strom, I think, has had 1 or 2 cases that she's told me about. There's methylene blue, so lower rate of anaphylaxis, but intradermal injections can lead to skin necrosis, and intraparenchymal injections can cause induration and erythema with associated pain. Important note, the dyes are contraindicated in pregnancy due to teratogenic effects, and so pregnant patients would receive the radioactive colloid. And so there's sulfur colloid, technetium labeled, human serum albumin. I think those are the 2 most common, although I know that there's some literature that supports others as well. Another technique for sentinel node biopsy is the targeted lymph node biopsy. I really didn't, prior to this, I didn't understand really what that meant until I really did a deep dive into it. And so for patients who are clinically node positive, who are biopsied before surgery, you can leave a clip in place. And so after they receive their neoadjuvant chemotherapy and then they go for surgery, you can perform a sentinel node biopsy on them, assuming that a clip is placed that can be found with, say, Savvy Scout. And from that Z1071 trial, they found that this reduces false negative rate in sentinel node biopsy. And it provides really important information in a patient who's node positive, who undergoes neoadjuvant chemotherapy. If you're able to get that node, you can see how their response was to the chemotherapy. And so for the sentinel node biopsy, if you've been in the OR with Dr. Strom, we inject in the subareolar space, massage for 5 minutes, and then your tracers will be taken up into the lymphatic system and go to those sentinel nodes. If you're doing a breast conserving therapy, once you get to the node biopsy portion, generally make a curvilinear incision, and then you'll use the navigator probe to find the radioactive colloid, and then for the blue dye, it's just gross inspection, looking for anything blue. If you're doing it during a mastectomy, a lot of times you can do it through the same incision, which is nice. Some investigational techniques in sentinel node biopsy. There's some literature that supports the use of indocyanine and green, but this requires a fluorescent imaging system, like we use with our gallbladders and colon cases, things like that. In a meta-analysis done by Suji et al. Of 12 non-randomized comparative studies, ICG was equal to or better than radioactive colloid in localizing sentinel nodes and tumor-positive sentinel nodes. Another one is superparamagnetic iron oxide. I'd never heard of that before. And this requires the use of a magnetometer to localize the nodes. There was a meta-analysis done of 7 studies in which the SPIO and standard tracers were used in each patient, and it was found to be non-inferior to standard techniques as far as identification rate, total nodes retrieved, and false negative rate. All right, as far as axillary node dissection, your standard axe dissection is removal of level 1 and level 2 nodes. Something that you need to know are your borders for your axe dissection. So superiorly, your axillary vein, medially it's your outer edge of the chest, so your serratus, and then laterally you have your anterior border of the latissimus dorsi and the thoracodorsal pedicle. And the way that I've done these with Dr. Strom is once you make your incision in the clavipectoral fascia, we start superiorly and work our way down. So you find the axillary vein and dissect it off, and then basically work top down, dissecting the axillary fat pad off. A good anatomical landmark is the lateral thoracic vein, and that's where your thoracodorsal bundles can be found. It's usually posterior and lateral, and you have to make sure you protect those as well as your long thoracic. All right, let's talk a little bit about the morbidity and financial implications associated with axillary surgery. So axillary node dissection, lymphedema occurs in about 20 to 30% of patients. Nerve injury around 5 to 10%. This study looked at long thoracic nerve. Infections were 5 to 15%. And range of motion issues were reported in to 20 to 30% of patients. And they reported permanent stiffness or weakness. And in the Sentinel node biopsy group, obviously less complications. You know, these lymphedema occurs in 5 to 10%. Much lower risk of infection, around 2 to 4%. I think the scariest morbidity is the false negative rate, so 5 to 10% false negative rate depending on your technique. And, you know, obviously if the patient has a false negative, that's going to lead to further treatment down the road. As far as financial implications of axillary surgery, the cost of axillary node dissection, direct costs average around $20,000 to $30,000 per patient, according to a paper out of the American Journal of Surgery in 2017. And that included hospitalization, surgery itself, and then immediate postoperative care. Post-surgical complications, additional costs for complications such as lymphedema and physical therapy, which can add upwards of $5,000 to $10,000 annually. And much lower costs in the sentinel node biopsy. Direct costs of sentinel node biopsy, $5,000 to $10,000 per patient. Cost effectiveness, the sentinel node biopsy was shown to be more cost effective by reducing complications and hospital readmissions compared to axillary node dissection. Indirect and long-term financial impacts. As far as indirect costs, for axillary node dissection, the recovery period is typically 2 to 4 weeks, leading to an estimated $2,000 to $5,000 lost in productivity due to missed work. Sentinel node biopsy recovery 1 to 2 weeks with lost work productivity of around $1,000 to $2,000. And then long-term costs, axillary node dissection, complications such as lymphedema and disability may require long-term care and management, leading to additional costs of around $10,000 to $20,000 per year. And obviously, sentinel node biopsy's lower morbidity significantly reduces the need for long-term care, lowering the total financial burden. I also wanted to look at the psychosocial impact of axillary surgery, and so a lot of this data is based on patient-reported questionnaires. As far as axillary node dissection, body image and self-esteem. So studies using patient questionnaires revealed that 50 to 60% of patients who undergo axillary node dissection report significant declines in body image and self-esteem. Visible scarring and lymphedema often lead to feelings of self-consciousness and embarrassment. And patients reported increased anxiety related to changes in their physical appearance. Psychological distress, 40 to 50% of dissection patients reported experiencing depression, anxiety, fear of recurrence post-surgery. Long-term psychological distress is more common in those with complications such as lymphedema or persistent arm weakness. Social and emotional surveys indicated that 33% of axillary node patients avoided social situations due to concerns about their appearance or physical limitations with their arm. This avoidance can lead to social isolation and further exacerbation of emotional distress. And in the sentinel node biopsy, these questionnaires showed much better quality of life. So for body and self-esteem, the sentinel node patients reported higher levels of body satisfaction compared to the axis section. Only 20 to 25% of patients who underwent sentinel node biopsy reported feeling self-conscious about scarring or changes in their body, and a lot of them expressed a sense of normalcy and greater control over their appearance. Psychological well-being, patient surveys revealed that 70 to 75% of sentinel node patients report lower levels of anxiety and depression compared to axillary node patients. And the less invasive procedure of sentinel node biopsy allows for greater emotional resilience, with fewer patients reporting ongoing fears of recurrence. And then as far as social and emotional impact, due to the less invasive nature and quicker recovery, 80% of sentinel node biopsy patients report feeling confident in returning to social activities and normal life routines with minimal emotional distress. All right, so now let's look into the new evidence, the newer studies that are coming out that are advocating for de-escalation of interventions. So given the significant morbidity and psychosocial impact that axillary surgery can have, it's imperative that the surgeon continually reevaluates the utility of more invasive procedures. As we make advances in systemic therapy, radiotherapy, and imaging, there's a trend to reduce the dependence on extensive surgical interventions. We're shifting more now towards more patient-centered, less invasive strategies, and are focusing more on quality of life while maintaining oncologic safety. So this is one that Dr. Strom told me about. I think it was intern year, but I remember her saying that she thought it would take a while for the rad-onc and med-onc groups to really to buy into it, and it's a recommendation from Choosing Wisely, and their recommendation was that it's safe to omit sentinel lymph node biopsy in breast cancer patients that meet the following criteria: age greater than or equal to 70, clinically node negative, T1 or T2 tumors, and that are ER/PR positive, HER2 negative. And a lot of these recommendations were based on several prospective trials that showed no impact. One of them was a retrospective review from Martelli et al. That evaluated the long-term safety of no axillary surgery for patients greater than 70 years old with operative breast cancer and negative axillary nodes clinically who receive adjuvant endocrine therapy. And what they found was axillary surgery did not increase overall survival or breast cancer-specific mortality. Cumulative 15-year incidence, T1 patients who received the axillary dissection was around 5.8%, and T1 patients without axillary surgery was 3.7%. Similarly, Chung et al. Evaluated the safety of sentinel node biopsy in women greater than 70 years old with T1 to T2 tumors. 5-year overall survival was around 70%. Breast cancer-specific mortality was around 4%. Ischemic heart disease was the most common cause of death. And the authors concluded that adjuvant therapy was less likely to be offered regardless of nodal status, which indicated that nodal status didn't influence care because these patients were likely to die from other causes other than breast cancer. Another trial was the IBCSG 1093 trial, which assessed whether omitting axillary surgery in older people would improve quality of life with equivalent disease-free survival and overall survival. A total of 473 women received primary breast surgery with adjuvant tamoxifen and were assigned to receive or omit axillary staging. And at the 6-year follow-up, there was no difference in disease-free survival or overall survival. And then the CalGB 9343 trial, which addressed the need for adjuvant radiation after lumpectomy in early stage hormone-positive breast cancer in older women. They did a sub-analysis of patients who received no axillary surgery or radiation, and only 3% developed ipsilateral axillary recurrence compared to no recurrences in patients who received radiation without axillary staging. And so due to the low axillary recurrence among those who had omitted nodal surgery and radiotherapy, they surmised that sentinel node biopsy could probably be safe in this population. This was a study, I think it was published in September of 2023. And this compares sentinel node biopsy versus no axillary surgery in patients with small breast cancer, which is, this is big data. This is practice changing. So this was a prospective, randomized, multi-center, non-inferiority trial. There were around 1,400 women with tumors that were less than or equal to 2 centimeters that were clinically node negative. And what they did was they performed axillary ultrasounds in these patients and then randomized them to 2 groups. There was an observation group in which they received no axillary surgery, but the patients underwent axillary ultrasound for surveillance. And then there was the standard sentinel node biopsy group. And they looked at disease-free survival as well as overall survival, recurrence, and morbidity. And so the key results from this was there's no significant difference between observation and sentinel node groups. At 94.7% in the observation group, 93% in the sentinel node biopsy groups. Overall survival was comparable in both groups. Axillary recurrence, the sentinel node group had slightly lower. Their low recurrence rates was around 1 to 2%, but it wasn't statistically significant. And obviously the patients who didn't undergo any axillary surgery at all had significantly lower rates of lymphedema and improved quality of life. So what they concluded is that in selected node-negative early breast cancer patients with a negative axillary ultrasound, axillary observation is non-inferior to sentinel node biopsy for disease-free survival and overall survival. And obviously the observation reduced surgical morbidity, improved quality of life. So that's a big study, because right now the current indications are invasive breast cancer. You get a sentinel node biopsy aside from the results of the Choosing Wisely papers. Right now, anybody that has invasive breast cancer, they're getting a sentinel node biopsy. But what this is saying is that if they have a favorable tumor and they have clinically are node negative and they have a negative axillary ultrasound, you can just observe them, which is, that's a big statement. And so, this supports de-escalation of axillary surgery in low-risk patients to reduce morbidity without compromising oncologic outcomes. So the next 2 trials are trials that are currently ongoing. I don't think the results have been published yet, and they're sister trials. The first is the Alliance 11202 trial, so axillary node dissection versus axillary radiation in breast cancer patients with positive sentinel nodes after neoadjuvant chemotherapy. So this is a phase 3 randomized multi-center trial. They include patients with T1 to T3 N1 breast cancer who have positive nodes after neoadjuvant chemotherapy. And so they're randomizing them to completion axillary node group. So they'll get the standard axillary lymph node dissection plus chest wall and nodal radiation. And then the other group is breast and chest wall radiation as well as nodal radiation without any surgery. And they're looking at disease-free survival over 5 years, overall survival, local regional recurrence, and morbidity. And their hypothesis is that radiation is effective enough that we may not need axillary surgery even in patients who have positive nodes. And so, that could mean that patients with positive nodes after neoadjuvant chemotherapy could avoid all of the morbidity with axillary dissection. And so I'm excited to see what this trial has to offer. On the other hand, the B51 RTOG 1304 trial, like I said, it was a sister trial to the Alliance study, and they took patients that were node positive, received neoadjuvant chemotherapy, and are now node negative. What do we do with them as far as radiation? And the current, what they're doing with the comprehensive group, so these patients undergo mastectomy or lumpectomy, and they get radiation as well as regional nodal radiation in the axilla. And then the other group, the standard RT group, is just post mastectomy or lumpectomy radiation just in your surgical bed. And what they are proposing is that maybe you don't need quite as extensive radiation in these patients once they go from node positive to node negative. And so I'm excited to see what the results of this study show. All right, final thoughts. Breast cancer remains one of the most common cancers worldwide, and is a leading cause of cancer-related mortality in women. It's our duty as surgeons that we must continue the tradition of critical evaluation to see if our interventions are truly needed, or can we scale back, and remembering, first do no harm. And so with ongoing trials that are shaping the field, there's hope for further de-escalation of interventions in breast cancer surgery. Thanks.
Thank you so much, Dr. Harvell. Does anybody have any questions or comments that you'd like to share?
Good presentation, Tyler.
Thank you.
I just had a question, I think, in regards to your indications for axillary dissection. Like you considered a patient and you're going in and you do not find sentinel lymph nodes, like if they were indicated to receive some, and that was an indication to proceed with axillary dissection. I didn't know in practice or here, because I honestly can't remember from Dr. Strom's rotation, do we go on and consent those patients initially for axillary nodal dissection to have that completed during that time of operation if they don't fall in the category of patients to where we can kind of choose wisely and watch and wait? Or do you bring them back to the operating room after that initial surgery?
I think a lot of it is patient dependent. I can remember from intern year doing a sentinel node biopsy with Dr. Strom, and we couldn't find sentinel nodes, but it was an older patient, and so we closed, and it was more of a discussion with them. Although I think a younger patient is probably not a bad idea to consent them for that in the off chance that you're not able to identify sentinel nodes. Dr. Strom, do you have any thoughts on that? Yeah.
That was a great presentation, Tyler.
Thank you.
You did an awesome job. I really appreciate that. And this is why it's so much fun to do breast people. People think breast is boring. It's so much fun to do because it keeps changing all the time. Mm-hmm. I think that's a good question, Devin, because it's still the rule, and I tell people it's the right answer on your AB site. If you don't find a sentinel node, do an axillary node dissection. However, looking at these last trials, and I think one thing to just clarify is that when NCCN is talking about, and papers are talking about clinically node negative, they're talking about on physical examination. Mm-hmm. They're not talking about on ultrasound, okay? Mm-hmm. And that's why the sound trial is I think, going to be a really important thing, because it's going one step further into ultrasound. I've had people where I've said, oh, why did I do an ultrasound? Now I know I have to do something about that node. Whereas if they were going to get chemo anyway, it would probably be negative. I'd never know they had a positive node, mm-hmm. and they wouldn't have to get axillary node. They wouldn't have to get axillary radiation. I'm going, too much information, too much information. So I think the Sentinel, I think the axillary part, and in answer to your question, Devin, I think that is something that we've discussed a lot because it is the right answer on a test to do the axillary node dissection if you don't find a sentinel node. However, with these newer studies showing that in clinically negative people, especially if ultrasound is negative, and now most people who come in, when they get their diagnostic workup by radiology, I'd say 90+% have had their axilla looked at. And if you don't see any, so I have had patients where I don't find a sentinel node. Pre-op clinical exam's been negative, pre-op ultrasound has been negative, their mammogram didn't show anything, and I'm going, in my heart of hearts, I don't think I'm doing them any good by taking out all those lymph nodes, so I don't. But I always say to my residents, it's the wrong answer on a test. So, for right now, but that's gonna be changing. I mean, the next 2-3 years, things are gonna change from that. And the sound trial, I think, is really exciting because the choosing wisely incorporates a little bit larger tumors because it's T1, T2 tumors, which can be then up to 5 centimeters. So, T1 is up to 2 centimeters, but it's only for over 70s. The sound trial included women of any age, but the caveats were that it was up to 2 centimeters in size, and it's ER positive, and it's HER2 negative. So you've got to have favorable breast cancers. You're not your high-risk breast cancer. Your favorable cancers that are relatively small. Now, it was done in, I think, 2 European countries and Chile. And, Americans, in so many regards, think that they're God's gift to earth. And so they have to repeat it in America before anybody's going to say, yeah, we believe this. But I believe it. I mean, I think, because I've been practicing that way, actually, for quite a while. I think the other question comes down when we do ultrasounds and we see something abnormal, biopsying it then. Because I think, I don't know if it was in one of your slides or if it was in NCCN, talking about if there's a positive node pre-chemotherapy, and there's still a positive node after chemotherapy, you're supposed to do an axillary node dissection. But all of you who've been with me know that there are those patients who you do a sentinel node, or you do an axillary ultrasound, there is one abnormal node, you see 3 completely normal looking nodes with fatty hilum, you biopsy the one node, and when you come back after your chemotherapy and take it out, that node is positive and you have 3 or 4 negative nodes. And although the right answer on a test is still to do an axillary node dissection, I don't think you're doing them any good.
Yeah.
And part of the reason is that, I mean, what's made the huge advances in breast cancer survival in the last 50 years, and if you look at the numbers, it's amazing. It's your systemic treatment. It is not your surgery. I mean, I say to patients all the time, as a surgeon, I would like to tell you I'm saving your life. I am not. It's your endocrine therapy, and if you need it, your chemotherapy, that's what saves your life. And so I don't really think that there's a big benefit in doing more surgery when it's because nobody dies of cancer in the breast. How many people have heard me say that? Everybody. You die of cancer in other places. So, so in people that I don't do the axillary dissections on when it's recommended currently, I'll follow them with axillary ultrasounds. I'll do ultrasounds on them every 6 months for the next 5 years, so that if there is a local recurrence, you find it early and you can maybe do something at that point. But so many of them never show up with anything because they're on they got their chemotherapy, and there's new chemotherapy all the time, the CDK inhibitors and other things that they're using for breast cancer. It's a whole paradigm change. And so surgery is going to be less and less important because of that.
Yeah.
But so y'all, this is why y'all need to attend tumor boards and listen to the discussions and try to keep up, because it really is interesting. And I think you covered everything. Well, I'm glad you covered the sound trial. I was wondering if you were going to, because it came out relatively recently. But I think that's going to be a great thing, and that's why I think an axillary ultrasound, hopefully we can really quit doing, of course, then you're not going to learn how to do sentinel nodes. One other thing I did want to say, because ICG is, everybody loves ICG, Molly. Everybody loves ICG. Remember that ICG does show you up your sentinel nodes, but it will also show up non-sentinel nodes, especially depending on how long the time period is. I mean, if say you're doing a mastectomy, you do your injection, and now an hour and a half later, you're coming back and doing you may find other nodes, and we found that. Who was on my service recently? Dylan. You know, so I think it helps you find the nodes because it does light up nice and pretty, but you got to make sure that node is hot.
Yeah.
You know, don't
Yeah.
just keep going and taking out 5, 6, 7 nodes because you got blue nodes.
Yeah.
It needs to be radioactively hot as well, you know, because ICG, I think it does, you know, the blue dye, it sometimes helps. It does, I'd say about 2/3 of the times it helps, and about 1/3 times it's no help at all. But I think the ICG is better than the blue dye. But just remember, you're not chasing ICG positive nodes. You're chasing your radioactively positive nodes, as far as I understand.
Yeah.
Anyway, but that would be an interesting thing to see.
Okay, thank you, everybody. Have a great rest of your day.